Go for it.
All right, thank you. All right, well, it's a real pleasure to get a chance to speak with all of you today, and I hope that you all can hear well and see well during these difficult times. This is a unique way to speak to a group of folks, but I'm glad that we're getting a chance to do it. I'll be leading the slides, most of the slides, and Dr. Edelman or John will be chiming in on some slides, and we'll be taking a lot of the questions and answers as well. So we're going to be doing this, the three of us together, Rabbi Eric, John, and myself. One of the first things that I want to point out in this COVID-19 Temple B'rith Achim discussion that we're having is that today's date is March 29th, 2020. And the reason why that's so important is that this is a very dynamic process. As you know, if you listen to the news 2 months ago and then a month later, and now it appears to be changing all the time. And it is, in fact. The numbers are changing, the understanding of the virus is changing, and also the recommendations that are evolving. So it's possible that you listen to this in a week and much of the information may have evolved. And that's okay. We want that because we want to learn more about this and keep getting better and better at what we're all doing. So with that said, I'll move on to the next slide. Okay. The first question is about when and where did COVID-19 start? So originally, it was not called COVID-19 at all. That was a name that has evolved. It's a coronavirus, and there's a number of coronaviruses, which we'll talk about in the next slide. But this particular coronavirus was first reported in December of 2019. The initial cases were associated with a South China seafood market in Wuhan, which is in the Hubei province. And there was beginnings and initial reports of human-to-human transmission. Again, we'll talk a little bit about the significance of that in a moment. Initially, that virus was referred to as the 2019 novel coronavirus, novel meaning new. It was abbreviated 2019-nCoV. So the N was for novel, the CoV was for coronavirus. Later on, that virus was renamed and a disease was named. So the virus itself is actually called SARS-CoV-2. You may be familiar with the term SARS because SARS, which stands for Severe Acute Respiratory Syndrome, has existed before. One that in hindsight could be called SARS-CoV-1, and this is now called SARS-CoV-2. So that's the virus. If a human gets that virus, then we would say they have the disease, and that disease is called coronavirus disease 2019, which is abbreviated COVID-19. So you hear people calling it the coronavirus or COVID-19, both would be correct. COVID-19 would be more specific to actually what we're doing here. And you can see in the pictures over there, that's where, in China, that's where Wuhan is. And you can see some pictures of a wet market where they have a lot of exotic animals, which is common in many parts of the world and is also common in China. So the question is, what are coronaviruses? Well, again, coronaviruses are a large family of viruses. There's many of them that are out there. Some of them cause mild illnesses. In fact, the common cold that we all get once or twice a year, hopefully not, but it happens, those are coronaviruses. And most of the time, those are relatively harmless, inconvenient. There's not a vaccine for that, but it's something that goes around in your workplace or at the synagogue or at your school or in your neighborhood. And you get that, and you take care of yourself, and you get better. There's also been a history of coronaviruses that have shown up that have been much more significant in terms of the consequences. You may have heard of MERS before, which is the Middle East Respiratory Syndrome, which is also called MERS-CoV. Again, that's Middle East Respiratory Syndrome, coronavirus. And that still exists in some parts of the world, but the major outbreak that happened years ago. And like I mentioned earlier, there was another coronavirus before called SARS, just like this is a SARS, and that's Severe Acute Respiratory Syndrome. And that caused a lot of trouble when an outbreak occurred in 2002, 2003, and that's no longer in circulation. Before I go to the next slide, let me just ask John if he wanted to comment at all.
So John had a little bit of a computer issue, and he's rebooting and will rejoin us in just a moment.
Understood. Well, then I'll keep moving along. So this next slide is talking about the origins of coronaviruses. So coronaviruses, they can start in people, they can start in animals. These outbreaks that occur that I mentioned previously, and this one here, started in an animal host. This one, we believe, started with bats and then found its way to people. Usually what happens with these kinds of outbreaks is that there is some kind of intermediate animal where it may start with a bat, for example, and then the virus itself will evolve or some way be contagious and affect some other intermediate animal, and then find its way to a person. These things happen, but the next evolution that has occurred is that if it gets to a person, and then people can transmit it to each other, and that has occurred here. There was a while where we thought that intermediate host, that animal likely between bats and people, was an exotic and cute animal to look at in pictures only, called a pangolin. It's a very scaly reptilian animal in China. And as of late, it looks like that may not be the case, that was, in fact, it's unlikely that is that intermediate host. So again, this can show up from time to time. A person could get sick with a virus, and with this virus, this novel coronavirus, which we call COVID-19, it has found a way to make its way to humans, and then for humans to transmit to each other. With that said, I'll move to the next slide. And John, when you get back on, you're welcome to just jump in whenever you'd like. So I'd like to talk a little bit about the symptoms of COVID-19. Now, the vast majority of people who get COVID-19, and by vast majority, I mean 80 to 85% of people who get it, will have no symptoms to minimal symptoms. And that's a good thing. We like that. There's some problems with that as well. But most people will get very minimal symptoms at all. There's about 15% of people who get it, and they in fact have more severe symptoms. And there's about 2 to 5% of people who get it that have the most severe symptoms. Now, the actual mortality rate we'll talk to in a couple of slides from now. So the question is, what are the symptoms? And there's a lot of symptoms that have been discussed out there, but the main symptoms I've got listed in the pictures on this graph here. So fever, and by fever, we're talking about 100.4 degrees Fahrenheit or 38 degrees Celsius. If you have a temperature that is a lower temperature than that, but still high, it's worth it to check your temperature twice a day. And we're going to get into more details towards the end about what you do if you think you in fact may have it. But fever, sore throat, cough, shortness of breath, muscle aches, diarrhea. Recently, there's been some news about some other symptoms that people may have, perhaps the inability to smell or taste the way you normally would, and that's still being explored further. But the predominant ones are the ones that I listed here. And by far and away, fever and a dry cough are the most common ones. And with that, I'll move on to the next slide. Okay, this cute little kid is sneezing or coughing here, and you can see the way the light is that it spreads. So let's talk about how COVID-19 spreads. And to some extent, this may be one of the most important slides we have here, because the way it spreads from a sick person to a healthy person is a relatively simple phenomenon. And all we need to do is we need to interrupt this simple cycle in some way. And that's how you can prevent yourself or your loved ones from getting it. So again, most people are being infected from other people. We think it spreads similar to the way colds and flu spreads. And of course, you saw on the previous slide that the symptoms that you get look just like colds or flu. So that can be confusing and concerning to a lot of people, but that's the nature of the virus, and we're not in charge of the virus. The virus is in charge of the virus. So it spreads in the same way. It spreads by respiratory droplets. So that means that if somebody coughs or sneezes, and then they go ahead and those respiratory droplets from their cough or sneeze goes out about a range of somewhere around 6 feet or around 2 meters to another person, or to a table, or to their hands. And then those respiratory droplets find it onto that table or to a doorknob or something, or to their hands, and then you or somebody else touches that surface that has those respiratory droplets. And then after touching it with their hands, they then touch their eyes, nose, or mouth, then they can go ahead and get it. So the whole strategy around stopping the spread is to interrupt that cycle anywhere along that chain. And again, I just described and laid it out to you, but it's actually rather simple. Someone's sick, they cough or sneeze, those respiratory droplets get to another person by some means, either they touch the surface or they sneeze or directly on them, and then that person brings the respiratory droplets that are on their hands over to their eyes, nose, or mouth, and then they themselves can become infected. So that's the whole mechanism. And I see that John is on, so maybe I'll just ask you to jump in.
Yeah, so I apologize for, after all the testing we did, in the middle of the start of the presentation, my computer needed to reboot. So I would like to just add one element to what Danny's talking about here. And if there are questions more scientifically related to some of the slides he covered already, particularly about the way the coronavirus gets from animals to people, I'll be happy to answer them when we get to the Q&A session. One additional point that Danny did not make specifically has to do with the level of contagion that this particular virus exhibits. Contagion is the descriptor used that identifies the period of time during which those respiratory droplets, so beautifully illustrated on this slide, contain virus that can infect somebody else. And while it is completely correct that respiratory droplets expelled by coughing, sneezing, even talking, when somebody is sick, has symptoms, and knows they're ill, are contagious, for this particular virus, it is possible for someone to not feel sick or recognize that they're sick, either in the beginning of the illness, on the average, about 4 to 5 days before their symptoms appear, or in some cases, it seems never ever having symptoms, they nonetheless have the ability to pass the virus along if they have it. And that's part of the reason for the advice to practice the kind of hygiene and distancing that we'll talk about in a minute, whether or not you have symptoms, but especially if you have symptoms.
Yep, that's perfect. So, you know, what a lot of folks, and you may know Dr. Anthony Fauci, you see him on TV and read about him all the time. He's been saying, act as if you have the virus, because you don't know. And in fact, it could happen that you do. And therefore, you want to make sure that you're not spreading it to anybody else if, in fact, you did have the virus. If you're part of that 80% of the population that gets it and has no to minimal symptoms. Okay, I'll move to the next slide. So this slide comes from Johns Hopkins website, which is tracking the daily count of reported cases around the world. And so we're going to break it down a little bit. I have 3 slides here. This one you can see here is the confirmed cases and outcomes globally. The next slide will be in the United States, and the next slide will be in the 5-county area where we are. So as you can see here, that the total number of confirmed cases is around 685,000 cases since this is started in December. Now, of course, this means it's the number of cases that were tested and reported and found its way over to Johns Hopkins. So there's a great chance that the numbers far exceed this. Again, if most people have no to minimal symptoms, then they wouldn't necessarily be tested. And if they do have symptoms, there may not be tests available. And so they may not be tested, and therefore it may not get reported. But that's the confirmed cases globally. You can see here on the right side that of that, there's so far reported about over 32,000 deaths, and over 145,000 people have recovered. It may be hard to see on your screen, but maybe not. You can see an order of prevalence, all the countries that their reporting. And right now, it turns out that the United States, unfortunately, is the world leader in number of cases. To be clear, China has 82,000 cases that have been reported since the beginning, since December, and the United States has 124,000. So we're followed by Italy, then China, Spain, Germany, Iran, and it goes on from there. How about I move to the next slide, and after this next slide, then John, if you'd like to chime in and talk about some of the significance of this as well. So again, this was the confirmed cases and outcomes globally. This next slide is the confirmed cases and outcomes in the United States. So, and again, these numbers come from today. I got them this morning. So the total number of cases that we have in the United States that are reported right now is 124,763. The total number of deaths so far that are reported is over 2,000, and the total number recovered is about 2,600. That's what's been reported and has found their way over. Now, again, I do want to just briefly focus on the fact that these are just numbers, and they're not as exact as they may seem. They're exact, and that's what was reported and registered by Johns Hopkins. But there is the possibility that many people who have it are not being tested, or there's not tests available, or they haven't been reported. And there's many, many reports. I have emergency physician friends who are telling me that that they're not testing many people that are clearly sick. They just don't have the tests, and it's so obvious that they're sick that they're just moving on with treatment. Before I go on to the next and local slide and the local count, let's go back to John for a second and ask if you have any thoughts or insights on these slides.
Yeah, thanks, Danny. So just a couple of comments I'd like to add about this particular virus and the comparison that's often asked for and made about regular seasonal influenza. So the first thing to say, if you simply take the numbers presented on these slides about the total deaths and divide it by the total confirmed cases to estimate the case fatality rate, so of the known cases, how many die, you will come up with a number that is vastly overestimating the true case fatality rate for the reason Danny said. The number of confirmed cases is undoubtedly underreported. That's true for several reasons, particularly in the United States, where not every person who has suspected coronavirus is getting tested, and particularly those who are not coming into the medical system because their disease is mild. But if you divide the two numbers that are there, the case fatality rate that is reported is 1.7%. And if you read the news reports and listen to the experts like Dr. Fauci talking about it, they estimate the case fatality rate is somewhere between 1 and 2% at the moment. In all likelihood, we will not know the truth about this epidemic, this pandemic, this worldwide epidemic, until it is over. And we have the opportunity to look back retrospectively to do more thorough investigations of total cases, and we'll know what the true answer is. The likeliest thing is that the value will be below what we see today of 1.7% in the United States. Compare that to seasonal influenza. The case fatality rate in seasonal influenza for the past several years, since the 2009 pandemic for influenza, has run about 0.1%. So if the case fatality rate for this virus is 1%, that represents a 10-fold higher case fatality rate. It is for that one of the main reasons that this virus is being treated so seriously. And even if the true case fatality rate, when we know it, is as low as 0.1 or 2%, there are two main differences that we need to keep in mind between this virus and influenza. The first is that there is at the moment no known treatment for this, unlike influenza. So if you have influenza and are diagnosed with it, there's treatment that is antiviral therapy. And the second is that there's no available vaccine to prevent you from getting this virus. And for those two reasons, and a host of others that I won't go into right this minute, this virus has the potential to do more damage and more harm to us than seasonal influenza does.
Thank you. Let's move on to the local cases here. This slide is shows a map of Pennsylvania, and we went ahead and specifically highlighted the 5 counties in our area, so Bucks County, Montgomery County, Philadelphia, Delaware, and Chester. And you can see on the bottom here this key that the darker red here are the areas, the counties that have the most cases, and over here in this kind of pale green color are the cases, are the counties that have the least. And you can see in our area of the state, that's where the most cases unfortunately are, and also in Pittsburgh as well. So you can see it kind of spreading out here. And I actually listed the numbers from this morning that I pulled. You have to navigate through the CDC website, but they do have reporting here. And you can see that in our area, the numbers in Bucks County is 152 cases, Chester is 116, Delaware is 226, Montgomery is 411, and Philadelphia is 709. Again, we assume that these numbers are a significant undercount of reality. The number of deaths that have been reported to date are 4, none in Bucks or Chester County, 4 in Delaware, 5 in Montgomery, and 5 in Philadelphia. So those will certainly rise, which is the reason why we have these talks, so we can know what we can do to try to prevent it. So how is it diagnosed and treated? We discussed this a little bit earlier. Diagnosing, there's really 2 ways to diagnose, and we could get into more details if you'd like, John, if you want to talk to this, but in short, there's the clinical symptoms that we've already discussed, along with the history, where if someone has those clinical symptoms, let's say a fever of 100.4 Fahrenheit or over, cough that's dry, muscle aches, these shortness of breath, if you have those, and also you were in touch with someone that clearly had COVID-19, perhaps they were diagnosed and tested, then the odds are that you have it. There's, of course, also, if you have the ability to get tested, which is becoming more and more available now, then that would show that you have it. Unfortunately, there is no specific medicine that actually cures this, as was just stated. So there are treatments that you or somebody else would get if they got it, but it's what's called symptomatic treatment. Meaning if you have a fever, they might give you something like Tylenol to decrease your fever. If you're dehydrated because you haven't been able to take any fluid or water in, they might give you IV fluids. A doctor might do that. If you're having a difficult time breathing, then they would give you supplemental oxygen and a number of ways to help you breathe better. And that's where you start hearing all these stories about the more extreme cases where just getting a supplemental oxygen under your nose called a nasal cannula may not be enough. And if it's really severe, some people need to be intubated and put on a machine, a ventilator to help them breathe. And so those severe cases, again, we're talking around 15% of people who get this have more significant symptoms, and around 2 to 5% have the most severe symptoms. Those more severe ends do require hospitalization. We'll talk later on about what to do if you are not those severe cases. But there is no vaccine right now, and there's no antiviral therapy for this right now. And we should assume for the moment that while we have a lot of heroes, including, I think, John, who's on the phone here, who are part of the group of people that are looking to find treatments and vaccines, those won't come for a long time. So because that's the case, we need to look for other ways to deal with this besides cures and vaccines. So, John,
yeah. Let me add just a couple of comments about treatment. Despite the fact that there are no proven and specific antiviral therapies, there are a host of things that are being tried. And the speed with which information about these things are being spread in the medical literature and then to the communities that are most severely affected is astonishingly fast. This morning, for example, I read a summary of a report just published in Lancet about the very first study with chloroquine, or hydroxychloroquine, which is a drug used for malaria generally, malaria prevention, and the one that the president is talking about. And I have to say, it was a study of something around 30 some odd patients, and it was promising. Of course, the measure in that particular study, as an example, was the rate at which patients cleared the presence of virus in their secretions, not whether or not their symptoms were less or whether their survival was different. It's early days, but I'm optimistic that the speed at which things are being tested and reported on will result in therapies that will eventually be available. And I'll speak more about this when we talk about part of the rationale for why we're all on Zoom having this meeting instead of in the synagogue.
Yep, and to that end, speaking about that specific drug, the drug that is used for malaria and also can be used for other things like lupus, so chloroquine, we do need to be quite careful. You definitely, if you ever have any symptoms or someone else you know has those symptoms, you want to be treated by a doctor. You don't want to take matters into your own hands. There has been reports of individuals who, after hearing that chloroquine was a potential cure for this, went ahead and took it themselves and had bad outcomes. So again, no drug is without side effects, and therefore you really should know what you're doing and have a protocol for how to take it. Otherwise, you could end up causing some troubles that are clearly not desirable.
One other point about vaccines before you leave this. As Dr. Fauci has been widely quoted, and he's right, the soonest a vaccine could be expected to be available is around 18 months, and I think that's right. But for the record, there are 42 documented approaches for creating a vaccine that are currently under investigation as of this moment. And actually, that I should say as of last week when I was on a call discussing this. So as of today, there are probably more. And a finally approved, fully available vaccine will probably take even several more years, but in all likelihood, if a vaccine shows significant promise, even after what's known as phase 2 research, it will likely begin to be made available to the people who are deemed to be at highest risk, or the areas in which the virus seems to be causing the most trouble. But that is not an immediately to be available. 18 months is the right time frame to be thinking about for even that kind of availability.
So the question is, in that context, what do we do about it? Since we don't have a cure right now and we don't have a vaccine right now. So how do we prevent the spread of the SARS-CoV-2 or severe acute respiratory syndrome, coronavirus 2, that virus, so that way people don't get COVID-19? What do we do? Well, the short of it is that simple cycle that I spoke about before, where somebody who's sick, whether or not they have symptoms, and all of us could be infected with this right now and not have symptoms. We all have to act as if we have it and avoid giving it to other people, our loved ones in our household and others. So we have to act that way. Interrupt the cycle of someone who's sick, giving it to someone else by coughing or sneezing or talking, and those respiratory droplets getting directly to that person or on a table or on a surface, onto the hands of that other person or onto your hands if you're the recipient, and then touching your eyes, nose, and mouth without having washed your hands first. That's the cycle that needs to be interrupted. So hand washing, regular old soap and water. If you all know, and maybe we should allude to Rabbi Eric can help us with this later on. There's a part of the slide that we've asked for his help with. But if he happens to be aware of any prayers that last 20 seconds long, and I'll give you a few seconds to think of one, that would be a great thing to say as you're washing your hands, because 20 seconds is the magic amount of time that we ask you to wash your hands, and that would take care of it. There's other ways to get it off your hands too if you don't have the ability. I can see him thinking right now for a 20-second prayer. But,
so Danny, let me just add something about soap and water. You covered earlier this coronavirus structure. You had a picture in an earlier slide.
Yeah.
We need to remember that this virus is a fairly large viral particle by virus standards, and it is covered in a lipid membrane. And the spikes, the proteins on the surface of it, are what it uses to gain entry into your cells. But the surface of the virus is made of this lipid membrane. And the most effective way of disrupting the virus is with soap, which disrupts the lipid. It breaks the lipid up. So washing your hands with soap and water is far better than using an alcohol approach to disinfect your hands. What alcohol does is it fixes the structure of the virus and ideally kills it. And that's fine if you're using an alcohol-based material that has at least 70% alcohol. So that's something important to check on. But the most effective thing is soap and water.
Yes, and there's the picture that you referred to before. So we'll go back to this slide. So we're looking to interrupt that cycle. Now, there are times that you just don't have soap and water. If you're going to go out to the grocery store and you're going to keep your distance, the 6 feet away or 2 meters would be the minimum distance that we'd like you to keep from other people outside of your household. Again, what we're talking about, unless you're sick, we're talking about physical distancing with people outside of your household at this time. If you do happen to cough or sneeze, then we want you to make sure you cover that. You're not covering that with your hands because then you're going to be touching doorknobs and spreading it yourself, and you don't want to be a spreader. And there's a nice video about that maybe Rabbi Eric will discuss later. And then you want to avoid touching your face. Again, that we're just interrupting that brief cycle from getting it from someone else who has it over to your eyes, nose, and mouth. So that's it. If you do have to touch your eyes, nose, and mouth, I want you to wash your hands first, especially if you're out on an adventure going shopping. So there's the keeping distance from people that are obviously sick. And if this happens, and this is a complex question that we may get into later, but it's very likely that it could happen that somebody in your household gets it. Again, the vast majority of the time, they'll end up having a good outcome. It'll be okay. But if they do, then to the extent that is reasonably possible, we want you to keep some distance for them, to have a space in your home that you can have them isolate. And we can get into the differences of the words isolate and quarantine later. But that would be the whole goal. And that's not always possible. If you have to care someone, if you have a child, if you have someone that you're caring for in some other ways, you can't always do it, and that has to be something. In the lower right-hand corner of this slide, I made a distinction here about the term social distancing, and just another way to say it, and maybe I'll hand this over to Rabbi Eric to comment. I'm going to unmute.
There you go.
Eric. There you go.
Yeah, so a number of people have been mentioning this in a number of different places during the last couple of weeks. I first heard Rabbi David Wolpe discussing this just about a week and a half ago. He talked about how we're using these terms of social distancing, but in fact, that's the last thing we want to do. We really want to be socially connected. We don't want people to be to a point where they're not connected with others. We need to distance ourselves physically, but yet stay connected socially. And it happens that there was a time when physically distancing ourselves meant that we were socially disconnected because there was no way for us to connect with others technologically or otherwise, other than being close enough for us to hear our voices in person. However, at this point in time, with the technology we have, we don't want to be socially distanced. We want to be socially connected while we keep our physical distance from each other. Little nuance, but very important, I think.
Thank you. Yeah, I think that was BZ or before Zoom, and now we're in AZ after Zoom. Okay, let's move on to the next slide. And this slide, you may have heard this expression out there, flatten the curve. I happen to like this picture quite a bit, and I'm going to hand this over to Dr. Edelman to discuss his thoughts on this and our strategies of what our approach is.
Thanks, Danny. So I'm sure if you've been paying attention to the news reports or reading anything about it, you've heard this flatten the curve. And I want to point out, and Danny, maybe you can use your mouse to show what I'm referring to, the light gray line, that curve, okay? And if you wouldn't mind, Danny, let's just briefly go back to slide 8. Because slide 8 shows what the curve looks like in the US. The bottom right-hand part of the slide, you can literally see the curve, okay? And what you'll appreciate is that in the recent days, the curve is showing that we are on the upslope of a very steeply increasing curve. Okay, so if we go back to slide 12, I think it is, right? If you pointed out, we are right now looking at a curve that looks like the left-hand side of this gray bar, and we have not yet reached the peak. And the idea of flattening the curve is to try and make the number of people who are sick and need the healthcare system match the capacity of the healthcare system to take care of them. 80% of people will not need to be hospitalized, but the 20% that do represent 20% of the number that we're at with that line. And at the moment, in places like New York, the number of people that need the healthcare system and the hospital-based system and the intensive care unit system is far exceeding the capacity. So the idea of keeping our physical distance, observing hygiene, of minding the way in which we interact with one another when we are sick or whether we've been exposed to somebody who's sick, to prevent the spread of this virus inadvertently from one person to the next, is to slow the rate of infection, which is what's shown in the yellow part of this curve. And the number of cases that are depicted here in the yellow curve is exactly the same as the number of cases that are depicted under the gray line. However, they occur over a longer period of time. And they occur at a rate such that the peak still allows the healthcare system to handle the number of cases. Effectively, what these strategies are intended to do is to delay the full spread of this virus. And because this is a novel virus that the human population has never seen before, the likelihood is that until we have a preventive, a vaccine, everyone who is exposed to this virus is liable to get it. So the entire population of the world is vulnerable to be infected by this virus. If we slow the rate of infection down sufficiently, we allow not only for the peak of the curve to be underneath the healthcare system capacity, but we allow time for that healthcare system capacity line to go up, to build healthcare capacity, like you see happening in New York, where they're building temporary hospitals and repurposing day surgical procedure units into ICUs and commanding General Motors to make more ventilators. The healthcare system capacity goes up with time. And it also delays the time long enough so that the research can bear fruit and an effective treatment can be identified, which will lower not just the rate of infection, but the total number of cases and the severity of those cases. So all three of those reasons, matching the case rate to the capacity of the healthcare system, allowing the healthcare system capacity to go up, and buying us time to identify an effective treatment that can be used, are reasons for everyone to be participating in this opportunity to slow the spread of the virus and flatten the curve.
Okay, thank you. I'm gonna give a couple of analogies here and stay on this slide for just a little bit longer. Imagine that we had a TBA, we had a community service project in the morning. We all did a great job. It did a nice mitzvah for our local community. This is pre-pandemic. And then after it was all over, we all finished and we all decided to go to our local deli and get ourselves a everything bagel with cream cheese and lox. And we all showed up at the same time, and there was 2 wait staff that were there. Well, what would happen is we would exceed the capacity if there was, it looks like there's 73 people on this call right now. So we would exceed the capacity of what those 2 wait staff could deliver. But if we all took turns going there and everybody kind of phased out of doing some people kept working while other people went and got lunch. Then we could all show up and not exceed the capacity, so those wait staff could take care of us and get our orders exactly as each of us separately want them. And that's the same analogy here, where we have a certain number of doctors, we have a certain number of nurses, hospital beds, ventilators, masks, all that. And if we can go ahead and avoid all getting sick at the same time, which is what this first gray curve is, and instead we space out when we get sick, then if we are part of that unfortunate group of folks that needs more care, our hospital system will not be overwhelmed like that deli wouldn't be overwhelmed, and they would have time to take care of us. That's one analogy that I think we might be able to identify with as a community here. Another point I just wanted to make about this is that this is a theoretical curve. I've already seen, there's lots of models out there that actually show what is known to be true curves so far. And unfortunately, what we're seeing is that there's been places, different countries, where they've done some good work in initially flattening the curve, preventing this and moving towards that. And then at some point, they give up on their physical distancing measures. And then what happens is you see, and any change that is implemented from a public health point of view, you always have to be careful about drawing any conclusions about it. It always takes about 2 weeks to see a difference. So anything that changes the next day probably didn't change because of something that you implemented the day before. But either way, what we're seeing is about 2 weeks later, after those physical distancing measures have been withdrawn, is that the number starts to spike up again. So we have to be quite careful, and it'll be very interesting to see how things go in China, which is quite very complex on what they're doing, but what happens with them as they start to ease their restrictions. And I do want to point out the cartoon on the bottom here too. To be clear, this is coming our way. So we're not going to be saying, oh, I hope it doesn't come to our county, that it's not going to come to Montgomery County in large numbers, or it's not going to come to Delaware or Chester or Philadelphia or Bucks County. It is going to come here. So we need to start accepting that that's the case. We are behind New York right now, but it's very likely they'll start. The models are that it would be in Philadelphia first, and then it would come to other areas. So we could go ahead and get very anxious about that. It's natural to. But in terms of panic and making decisions that are not thoughtful decisions, that's only going to hurt. So the key thing is we don't want to, and we don't need to, and we shouldn't panic. We just have to be smart. And we're a smart group of folks, and we can make smart decisions. So as it comes, and each of you will have stories every day of someone else you knew, or someone else loved, someone in our congregation that gets it, and they'll start coming closer and closer. And when it does, we just have to be prepared. We have to do these simple things that we're talking about doing here. And we'll be all right if that's what we do. We really should be all right. Just got to be smart about it. Okay, I'll move to the next slide. John, you want to talk about this slide?
Yeah, thanks. So this is a common question. What do I do if I'm sick and I want to be tested? How do I get tested? In the state of Pennsylvania, the first place that COVID-19 testing was available was in the Pennsylvania Department of Health. And in order to be tested, you needed to qualify with a series of criteria, including having recent confirmed exposure to somebody with COVID-19 or having been from a country where there was exposure to COVID-19 and have significant symptoms, and you needed to be approved and be scheduled and go to one of the few testing centers in Pennsylvania. In the past 10 days, those restrictions remain in place for the Department of Health testing. However, the state has now permitted any doctor to order a test from the commercial laboratories or a hospital that has authorized to do it. And in Pennsylvania, there are hospitals and commercial labs that are doing it, and you do not need any special permission for that. So if you feel like you want to be tested and you feel fine, you're just worried, you shouldn't get tested. That's the recommendation. But if you have symptoms or have been exposed to somebody who has symptoms and you want to be tested, your first port of call is your physician. And your physician will be able to tell you where and how to get the test done. It's almost never necessary to go into the doctor's office to get that test. You can go to locations where the commercial labs are doing testing, but your local doctor will be the one to tell you where to go. And in the state of Pennsylvania, if you don't have a physician, you can call the number at the bottom of the screen, 877 PA Health, and be referred to a healthcare provider. We'll talk a little bit in the Q&A session about, specific circumstances if you have them and want to explore some of those more. But the general answer to the question of how should I get a test if I think I need one is to call your doctor and ask the question there.
Right, and we really want to emphasize the calling bit. There's a lot of capabilities that are emerging and happen to be long overdue, and I'm glad that they're happening with teleconsultation. Doctors may be able to video with you initially, but calling is important because your doctor may not be seeing anybody with a fever. That he or she may refer you elsewhere. And the same goes for an urgent care or frankly for an ER, emergency department. They may give you advice on if you do need to go to emergency department, and calling them first is important because they may say, oh, you have these symptoms. Let's say it doesn't look like COVID. Let's say you have something else that happened that is not related. They might say, for people that don't sound like they have COVID, we'd like you to go to this door. And for people that do, we'd like you to go to this door. Or they might even say later on, as we triage our hospitals, they'd say, don't come to our hospital. We're only seeing people who we think have COVID. Go to this hospital, which is where we're having people who don't have likely COVID are going. So it's really important to call first. With that, I'll move to the next slide. And this slide is actually meant for Rabbi Eric as well, to talk about some of the non-medical things we can be thinking about doing at this time that we learn in synagogue all the time. And if you happen to have something, and no pressure, but if you have that 20-second prayer, that's great. If not, I bet someone else can come up with a good prayer for hand washing that takes that amount of time. All right, Rabbi Lazar, I'll hand it over to you.
So funny you should ask about that. A couple of things. First of all, one of my original messages early on in this time of challenge that we're facing. I'm going to steal the screen from you for just a minute. I sent everyone where is it? A link to something from an organization called Ritual Well, and it was this.
I don't know if you want to turn on your video also.
Hang on one second. Oh, thank you. Sorry. So, here we go. So there was a blessing that was sent around from an organization called Ritual Well, and it's if you go to ritualwell.org, they have on their homepage a video of someone washing their hands and saying this blessing. And basically it says, as we wash our hands, we pray, blessed is the soul of the universe, breathing us in and breathing us out. May our breaths continue and our health and the health of all be preserved in this time of sickness and fear of sickness. Holy wholeness, we take as much responsibility for this as we can by observing the obligation to wash our hands thoroughly for as long as it takes to say this prayer. Amen. Baruch atah Adonai Eloheinu melech haolam, asher kedeshanu b'mitzvotav v'tzivanu al nitilat yadayim. Blessed are you, our God, ruler of the universe, who sanctified us with God's commandments and instructed us on washing hands. This last part, this chatima, this signature line, it's not a new blessing. It's been part of our tradition for years. There's a hand washing at the beginning of the Passover Seder and at other times as well, before Shabbat dinner, before any meal for that matter. The prayer about washing hands, the blessing for washing hands, has been part of our tradition for years and years and years and years and years. So that's one thing. Another thing is to make sure that you're not doing things that you shouldn't be doing, that we're not putting ourselves in a position of potentially affecting others. Some of you have seen this. Come on. Well, maybe it won't play, but anyway, this is Max.
sound is not.
Yeah. I don't know if you're
Don't hear it.
No.
can't hear it. Is your volume up on your computer?
All right. Well, it doesn't really matter. What's important is that if you have a chance to find this on the internet and you watch it, it's Max Brooks, Mel Brooks' son, talking about don't be a spreader. It's not about what affects me necessarily. It's about my potential to affect others, right? The distancing from each other physically, avoiding crowds, washing our hands 6 feet away. And if you have the opportunity to stay home, just stay home, at which point Mel Brooks from behind the glass door of his house tells his son to go home. And so he does. He walks away and goes home. But that's another important thing. And just to, I'm going to stop sharing and give Danny back the opportunity to put up his screen. But I just want to just to remind everybody that we don't, the important, that it is really important, what the point I was making before about not, not distancing ourselves socially, but physically. That's really the important part. We need to be reaching out to each other. One of the things I mentioned on Friday evening when we came together, we had almost 40 households together for our Kabbalat Shabbat experience. We had Matt Shapiro leading on guitar from Florida. We led the service together. That was really, it was just wonderful, everybody coming together. We had a virtual oneg afterwards. We connected in ways that were important while making sure that we weren't connecting in ways that were potentially dangerous. But one of the things is we need to remember that some people are also feeling bad for lots of different reasons. Some people are feeling bad because they don't have access to certain resources. They don't have the availability to go and do the things that they usually do. Some people are feeling bad because they're not able to help in the way that they've helped. I was just having a conversation today with someone who was talking about people who are so used to doing their volunteer work, and now that they're not allowed to do what they usually do because of the physical contact that it involves, are feeling bad about that. So we've got people providing assistance who are feeling bad about not being able to do what they do. So it's really important we stay connected, that we reach out to each other. As Rabbi Larry Kushner has said, we are a hopelessly communal people. There are hermits and monasteries are conspicuously absent in our history. And so we need to make sure that we connect in whatever way we can. My suggestion, one suggestion, there's a lot of suggestions. Take out the membership directory, go online, find a name in the membership directory of someone you don't know, just give them a call, just once. You want to do more, but just reach out to somebody and make sure that people know that we're all connected with each other. I think that's really important. I think at this point I'm going to, I mean, there are plenty of more things to do, but and ways to help, but I don't know if Danny and John, if you have more things you want to share before we start with question and answer, or if you want me to elaborate more.
Yeah, I'll just move to this last slide here. I saw that Rabbi Sharon is on the listening as well too, so you got a little picture there. And thank you. But at this time, it's time for your questions, and we'll all say thank you. So let's take it away, Rabbi.
Okay. So I have not received any questions in the chat, and I don't see any hands raised. So let me, I have, allow you to unmute yourself. Oh, there we go. There we go. Okay, so first question, wait, where'd it go? Ooh. First question comes from Jerry and Lois. Go for it. Oop, I just unmuted you. I'm trying to unmute you and it's not working. Hold on a second.
I'm unmuted.
Okay, great.
Here I am. A technical question. Going off of the image of the sneeze and all the water droplets, and I've heard a distinction made between water droplets and aerosols. Is there a difference, and are they both to be avoided?
Yeah, let me grab that one. So, no, there's not a meaningful difference. What you are seeing is the aerosolization of secretions coming from the mouth and nose that come with a sneeze. You may think of a sneeze as coming out of the nose, but most of what comes out in a sneeze is coming from your mouth. And the difference between an aerosol and water droplet is the size of the liquid. The virus particles are, infinitely smaller than the droplets, even in an aerosol, even in the mist that you're seeing there. And the important thing to know is that the life of the virus that can infect you when that water droplet or that mist lands on a surface is not fully known yet. The estimates are about 3 hours, although there have been, depending on the surface, records of the virus being able to be recovered after 12 hours. That's one of the reasons why you're encouraged to kind of disinfect surfaces that you touch frequently. And if you've been out to the grocery store, for example, you should see that they are frequently disinfecting things you don't even think about, like the keypad to put in your phone number, when you're checking out, things like that. So there's not a meaningful difference between water droplets and aerosolization for containing virus. There's a difference in how far they can travel and how quickly they land. Aerosols will go further than water droplets. Aerosols will land more slowly than water droplets, but not in terms of infectivity.
Yeah, and some of the concerns for there are viruses that have a more significant aerosolized spread. This one doesn't as much, so it's heavier and it's mostly in the bigger droplets. So, like at some points there were concerns, for example, that if you lived in an apartment building, it could find its way into your heating and cooling, your HVAC system, and that it go up and spread from apartment to apartment, things like that. That's not thought in any way to be a common way that this is spread, and that's some of the more fine aerosolized spread that could occur with other viruses and not this one. So the vast majority of time we're talking about within 2 meters or 6 feet of the person who's sick and the path that they've walked on and the path that they've spread their respiratory droplets.
All right. Next question from Scott.
Can you hear me?
Yes.
Okay. Actually, 2 questions. One of them was, yes, I was wondering how long the respiratory droplets do stay live on a surface. I mean, if somebody were to touch a doorknob, how long they could stay on there. And you were saying it could be, I forget how many hours you said, but that was one of my questions, how long droplets could stay live on a surface once you touch a surface. And then the other question was, I'll ask them both, is it regarding physical distance within a household? So if you're in a house with somebody else, I'll give a great example. My older brother lives in Boston. He has 2 daughters that live in Manhattan. And he went down to Manhattan on Friday to bring them up to Boston to get them out of New York. And the one daughter is married and has a child that's 6 months of age. So they're now all under his roof in Boston. What kind of a physical distance should they be having from each other within their own household?
Yeah. Okay. Want to take that first, Danny?
Sure. Look, it's really hard to physically distance with people in your household, and it may not be practical to do that. There are some circumstances where you would want to do that. But for the most part, if you're doing the job of essentially quarantining, where you're staying in your house or away from other people, maybe you go outside, maybe you, with a lot of caution, go grocery shopping, but you're doing a good job of keeping your distance from other people outside of your household, then it's thought to be fine to be interacting with people in your household, and you don't need to be afraid of that. There, of course, are some circumstances where we want to be more concerned about that. If someone's got obvious symptoms, then yes, you would want them to come up with a strategy, which I know would be very difficult in a house to be separate. And it's something would be worthwhile thinking about what you would do if someone in your household did start to become sick, and what are the logistics in your physical space. If someone in your household has just traveled or was in an area where there was a high degree of spread, or there's a reason to think a high likelihood that even though they're without any symptoms, that they really could have it. They were spending more than 15 minutes of time with someone recently who became coronavirus positive, or something like that. Then it would be worthwhile at that point, even though difficult, to take your 14 days and decrease contact. But I understand that that's quite difficult. What we want to focus on is things that you can do. If you can't do anything about it, well then some things you got to let go. John,
can you still hear me?
yes.
Brian Korf.
Yeah, Mr. touched on a little bit with the aerosols, but I think it's important for you to let everybody know how long the virus lasts on specific surfaces, metal, aluminum, plastic, and that sort of thing. If you have that data, that would be helpful, because it's very important to realize that it lasts a long, long time.
Yeah. John, I have some vague numbers. I don't know if you have more specific numbers. What I would.
Go ahead, Danny. Start.
Yeah, I mean, you are exactly right that the different qualities of surfaces, whether it's glass or metal or wood or cardboard packages, they have a different length of time that they're likely to stay alive, that they could stay alive. Doorknobs that are metal or wood, etc. So on packages, all the information that's coming out, stuff that's mailed to us, that's the easy one. It's thought that viruses that could have found its way into packages have not been a significant source of spread. And while we could take precautions with them, if it's a box or a mail, you could put it in a location on your porch or in your mailbox for a day and then go get it and let it sit there. It's not thought to be a significant source of spread. Things like your phones, the glass on them, and other things we might forget about, our glasses ourselves, harder surfaces, metals, woods, that can last longer. And the information I've read is at least 48 hours, but I've seen data that goes much, much longer than that, as much as 17 days or so. So, John, I don't know if you have anything more specific, but either way, I just part with this point before going with John, that's a reason if you if you think you've been somewhere or someone else has been who could be sick, then it's important to wipe it down. But John, do you have some more specific numbers?
Well, I want to say that in the beginning of this, the estimates of time that the virus was capable of remaining infectious outside of a host, right, were measured in days or described in days, but that does not seem to be the right answer as more information has come forward. Generally speaking, the smoother the surface, so metal, glass, the longer the viral particle remains present in a form that you can pick it up. And remember, just touching it does not cause infection, right? So if you are conscious of, and I can tell you from personal experience, I've become personally aware how frequently I do touch my face without even thinking about it. If you're conscious of that and avoid touching your face and wash your hands after touching a surface that you're not sure about, you can do a lot to protect yourself. And what I would say about the household, your experience in the household, it will be very, very difficult if coronavirus enters your home to keep it from touching everyone who is in the home. It'll be very, very difficult to do that. The point of this physical distancing is to keep one home from infecting another home, and to avoid the spread of virus in crowds where they then move and disperse to go to many different places. You may have read about New Orleans having one of the highest case rate increases anywhere in the world, if not the highest, which they are attributing to Mardi Gras, Fat Tuesday, and the presence, despite the the awareness that this virus was in the community, the presence of crowds of people in close proximity to one another who then all dispersed. That's the main thing that this kind of physical distancing is meant to accomplish. In terms of the way in which you treat surfaces that you have a worry about, it's important if you're trying to disinfect that you do so with a disinfectant, a chlorine-based disinfectant. Right? I was in the supermarket and saw some Arm & Hammer lemon-scented wipes that have all natural ingredients, for example, and I went and looked it up, and there's not sufficient disinfectant ability in those wipes. Right? So you need to be using Lysol or something else that's chlorine-based in order to effectively disinfect. And most importantly, once you're done, wash your hands with soap and water before you touch your face.
So along those lines, if we go grocery shopping and we bring home boxes of cereal ordered from a delivery, should we leave it in the garage or on the stoop for a day and a half? Or when we bring it into the house, do we have to wipe down every container of every food stuff that we bring in?
Yeah. My answer to that is there's nothing wrong with leaving your materials, without touching them beyond what you did when you were in the supermarket, to put them in your cart and put them in the bag and so on. There's nothing wrong, but it's not so far been an established form of transmission of the virus. And I think, we need to be sensible and not make ourselves crazy. All of the retail supermarket chains have instituted more narrow hours and more intensive cleaning routines. The stores that I've been in recently have been wiping down the conveyor belts, for example. I do advise that you do the least amount of touching and pay attention to touching your face and wash your hands when you get home. I think that's good common sense practice.
Right, because a lot of people will take something off a shelf, decide they don't want it, put it back, and you don't know who touched it. But as long as you're not touching your face, that's really important. Wash your hands. All right, next question comes from Dan Burnham.
Hi, this is Dan and Hannah. Going back to the flattening the curve here, you have the tall peaked curve and the flattened curve. And there was a statement that the area under the two curves is the same, suggesting that the number of cases in either scenario would be the same. That doesn't seem like it's necessary that they be the same area if the flat curve is resulting from physical distancing. The reproduction number for the virus, or the likelihood of being transmitted to someone else, should be less, and thus there'd be fewer cases generated.
Yeah, Dan's talking about the R naught value, which is the rate at which an infected person infects other people, and the factors that control whether or not, how high that number is, whether it's one, in other words, one person infecting the next person, less than one, in which case the virus will eventually disappear, or greater than one, which is the case currently for this virus. The factors that control what that are not fully known for this virus, but for generally relate to the length of time that a person who is contagious, that is, has the virus, is capable of spreading it, and but does not know that because they're not sick. The longer that period of time is, the higher the likelihood that that person will infect more than one person, and that will create an R naught of greater than one. The goal, the epidemiologic goal to contain a viral illness is to get that R naught value to go below one. And if you can, in a sustained way, cause the virus to not be able to spread to a new host, it will disappear. So in theory, Dan's right, that you can flatten the curve to the point where the virus that is present in all of the people who currently have it, runs its course, and has no further host to be transmitted to, the people that have it, their own immune systems deal with it and eliminate it, the virus is then gone from society. But the reality is that this virus is unlikely to be gone from simple epidemiologic practice. And so the immediate goal of flattening the curve is to match the rate at which cases occur to the ability of our healthcare system to take care of it, to buy time for that capacity to go up, and to buy time for treatments to become available, which will definitely have an effect to lower the full case count and drop the R0 value down to 1 and then below 1.
All right, next question from Lori and Pete.
Yes, first of all.
Okay, we just unmuted you, sorry.
Can you hear me now?
Yes.
Okay, so first of all, thank you very much for doing this presentation today. It's been really, really helpful. I do have a question about the vaccine. So I go and get a flu shot every year. And the reason I believe I do that is because the flu virus mutates frequently. And so last year's shot is not going to be as potent as the one that's created for this year. So if the vaccine is not going to be ready for another 18 months, is it going to be effective against the strain that we're fighting now?
Yeah, it's a great question. Thanks for asking it. So a couple of comments about vaccines. As vaccines are researched, two things are happening. One is a determination of whether or not that vaccine is effective in preventing the disease. The other thing that's happening is the platform, the manufacturability, the way in which the vaccine is made is also being studied and confirmed. For the influenza vaccine, in fact, what's approved is the way in which it's made. And each
You're frozen.
vaccine is used to make vaccine. So each year, a new vaccine effectively the new vaccine is effectively approved. So the question is whether or not this particular coronavirus, SARS-CoV-2, is changing sufficiently that the vaccine that they make against the current virus will be effective. And the answer to that question at the moment is, although the virus is changing genetically, it does not appear to behave the same way as the influenza virus does. It is not changing sufficiently at the moment for us to be able to predict whether or not the vaccine made and available in 18 months will be effective against this strain. However, the method by which these vaccines are being made will be able to adopt and adapt and adopt the newer strain if that becomes necessary.
Okay. Now, next question from Mark Anaranda.
Yes, this is Mark. So I have a question about the testing. Can you say something about false positives and false negatives? How much of that is involved with these tests, and what is the implications of that to the healthcare policy?
And just quick before you answer that, excuse me, some people have sent me questions privately in the chat. I will be asking those. I'm just going through kind of in order, picking people whose hands are raised. So I will get to your questions that you've sent me privately in the chat. Go for it.
All right, let me start. The short answer to your question, Mark, is I don't have the false positive and false negative rates. To quote you, maybe Danny has them or is looking them up as we're going. But what I will do is describe briefly the testing methods. You've all seen pictures of people driving in cars and, you know, rolling down their windows, and somebody who's fully covered in protective gear sticks a swab in their nose. Those tests, those were the initial tests, are looking to detect the presence of viral genetic material through a process called PCR, or polymerase chain reaction. Initially, that was only being done at the CDC. It was then spread to other regional laboratories, and then eventually that test was made available to commercial labs and using high throughput machinery and so on. More recently, however, there are new tests that are being developed that measure the presence of antibodies that your body makes against the virus that are specific for the virus. And the speed with which these new tests are coming online is pretty amazing. Their availability, though, is varied because they are, for the most part, commercially created. And the answer to the question of what are the false positives and false negative rates for each of them is going to be important to understand. Particularly false negatives, people who actually have the disease are tested, but the test fails to demonstrate it. A false positive may cause undue, restrictions on somebody, but it's not a terrible thing. And obviously a true positive is highly valuable and a true negative is highly valuable. Although the value of a true negative, let's not forget, if you don't have the virus today, it doesn't mean you can't get it tomorrow. The most relevant test has yet to be rolled out and will be, I would predict, within the next several months. And that is the test to tell whether or not you have immunity to the virus, right? Whether you are safe from the virus. There is a community in Colorado you may have heard about where they're a county where there are 9,000 residents. They're testing everybody with this measure, an antibody test that is intended to determine whether or not they have immunity against the coronavirus. And that test, I think, is going to become widely available and recommended, particularly in areas which are heavily involved with this, like in New York and Washington State and California. But it's not going to be long before every major city in America will be having their own New York City-like challenges. And I think the availability of that kind of a test, which can tell you whether you're immune, will be the most informative and helpful test for people to understand when and how we can potentially begin to ease up on this isolation. Danny, anything to add about rates of false positives?
No, yeah, you said it perfectly. It simply is not known right now. I was speaking to a friend of mine this morning. He's a doctor at University of Michigan, and he spoke with the lab at the hospital there, and they're saying and asked the same question. And there's so much variability that has been used with how the tests are conducted, and actually the nuances of what actually happens with the samples, that it'd be impossible to give a consistent answer. We're just simply not at a point yet where we have a uniform practice in how we're conducting our tests and the testing materials across the country. So, I know that's frustrating, but that's the nature of an outbreak of a novel disease.
So, for those of you who have children who have not yet graduated high school, we're going to be doing a presentation either tomorrow or Tuesday. Want to know a good time? So check out the poll question that will be coming up in just a moment. Please answer that if you have kids in the synagogue. But now we have a question from William's iPad. I'm guessing the iPad is going to ask the question though. William, are you there? Yes, no, maybe so.
I'm here.
Here's some background noise.
Yeah. William's microphone is not active.
Okay.
So William, maybe you want to type the question in the chat box.
So there was a question. There was a question about.
Oh, now William's microphone is active. So if you unmute William, maybe that'll work.
Okay. William, are you there?
No, it disappeared again.
All right. So I'll go through a couple of questions. There was a question about someone says that they take hydroxychloro as part of their chemo for aggressive rheumatoid arthritis. Do you think there will be enough available in 2 months when we need to get more with methotrexate?
Yeah, it's a good question. So hydroxychloroquine is one of those drugs that is in the process of being tested to see if it's effective in treating and even potentially preventing coronavirus disease, COVID-19. But it's used for other things, which is what William's asking about. What I've seen is really anecdotal reports of the efforts of the companies that make these drugs to make millions and millions and millions of tablets of this available. But it wouldn't be the worst idea to look for an early refill if it's something that you need to take for reasons not related to COVID-19.
Yeah, we at my company, International SOS, we've had a lot of our clients of ours ask us to try to procure large quantities of chloroquine or hydroxychloroquine. And there's two steps we took with that. One was that we told them that we wouldn't do that because it's not proven yet, and we don't want to be participating in using something that is not proven yet and potentially causing harm. But in the process of answering those questions and telling our clients that we weren't going to do that, we also did take a look and see how available it is. And right now there are shortages nationwide, it's true. So we have every reason to believe that the manufacturers of that drug are currently rapidly increasing the quantity that they're producing because of the demand that's going up. So hopefully in that time it will be available. But yeah, if you take it for a particular reason, you may want to speak to your doctor, discuss that through, and see if he or she is willing to write you another script at this time with a larger quantity.
And speaking from personal experience, I could say that if you have a pharmacy plan, health plan, they've been very accommodating in terms of emergency fills. Diane and I are in Florida and have been here for a month. We didn't intend to be here for that long, but that's where we are with my parents. And we've had to get these emergency refills of our routine prescriptions, and the insurance companies have been very cooperative about that. So I think, that's worth a phone call. But I want to emphasize what Danny said. Under no circumstances, unless you are a physician, should you be trying to obtain and self-medicate with hydroxychloroquine or chloroquine or anything else for COVID-19. You must be under the care of a physician. And for the most part, the use of these drugs, it's critical to be gathering data about whether or not they work and how safe they are in order to make the kinds of recommendations that would make them available to all of us if they in fact prove to work. And using them outside of that kind of a circumstance, that is, with medical supervision, is really a terrible idea.
So I'm going to field this question about rituals and funerals. The Board of Rabbis of Philadelphia has been in touch with other boards of rabbis around the country and around the world, quite frankly, and there have been lots of discussion about this. There is an actual directive that was sent out for clergy officiating at funerals, and there have been, unfortunately, as they always are, during the past couple of weeks, there have been locally as well, and there are provisions for it in terms of immediate family only, for those who use the shovel, to make sure that people actually brought their own shovels, that they didn't touch the shovel and then someone else touched it. They stood, distanced from each other, 6 feet away. I was talking with a colleague earlier about how this was the first time that they ever left the cemetery without the first time they said Kaddish before the grave was actually full, because traditionally we don't mourn until after the body is buried, so we wait for the earth to be put in the grave in order to say the Kaddish prayer. And they said it was different for them in all sorts of ways, because everybody had to kind of say the prayers and leave, and then the cemetery workers would fill the grave. And so it was a different experience for them. So there are provisions. It's not easy when it comes to Shiva. There are lots of suggestions and things that are in place that have been happening and are available. God forbid that has to happen. I've been speaking with people in our congregation about those kinds of things as well. People have contacted me already. So there are provisions for that. One question is this a seasonal thing? And if you get it, can you get it again?
Yeah. I'll start with that. So the short answer is nobody knows yet. It is correct that other viruses in this family, and believe it or not, I don't know if Danny covered this in the early part of the talk, the coronavirus family has 4 members, and some argue 5, before this particular virus that regularly circulate in the human population. They cause the common cold. They've been present in humans for hundreds, if not thousands of years, but certainly for a long period of time. They generally infect younger people, kids, and appear to be seasonal. So that means that they're more prevalent in the colder weather in the wintertime. They tend to abate in the warmer weather, and then they come back again the next year. The epidemiologists are very closely watching the way in which this particular coronavirus spreads around the world, because remember, the northern hemisphere is entering into the warmer summer months, while the southern hemisphere is exiting and entering into the winter months. And so the answer of whether there will be seasonality is going to be answered by making observation. It is certainly possible that this virus will become more quiescent as the weather gets warmer and resurge or recur as the weather gets colder again, but that is not a guarantee. It is not absolutely known. One other thing to say is that influenza, I'll give you as an example, influenza, which is clearly a seasonal virus, when it became a pandemic, when the swine flu H1N1 virus emerged, a virus that had not been seen in humans since 1918, reappeared in 2009, it did so in the United States in the summer, in the spring and summer. So the idea that whatever the behavior of this virus will be once this pandemic has ended and the exposure to the human population has reached a point where spread is no longer happening at this alarming rate, that is unknown, but it is without a doubt able to be spread now, irrespective of the weather in the moment.
Okay.
And one more thing on the one and done. The evidence so far appears that the antibodies that people develop against the virus that are neutralizing, that if you take these antibodies out of somebody from their blood and you put it in the petri dish and see if you can block the ability of this virus to infect cells, the answer appears to be yes, that people who are becoming immune are making neutralizing antibodies that block the ability of the virus to infect new cells. That is a good indicator that once you get this virus and get over it, you are unlikely to be able to be infected with this same virus again. That doesn't mean if the virus changes sufficiently that you will be protected. That remains unknown. But as I said, so far the evidence seems to be that the virus is not, although there are changes in the genetics of the virus, the way it behaves and the way your body recognizes it don't appear to be changing sufficiently to make that a worry.
Going back to the question about the prescription, the response in the chat was we did get an early script, but they only gave us a few months worth. Very scared and can't or won't get again. It took us days to find 2 months worth. When do they think testing will be available to see if we had it? Then they can use our blood to help people they currently have it. And I saw something this morning about on the news about people who have recovered or are recovering, that they can take those antibodies from them in the plasma and inject it into others or something along those lines.
Yeah. So I can speak to that as well. So based on results of what's called the use of convalescent serum from China, and a very small study, but showing a pretty good effect at Mount Sinai in New York, for example, and other places around the country. They are beginning the use in clinical trials of convalescent serum, that is to say, people who have had the virus, have recovered, taking their blood, isolating the serum proteins, the immunoglobulins, the antibodies from their serum and using it as a therapeutic to treat the most severely ill people. In addition, I mentioned earlier there are 42, there were, when I last heard this, 42 different vaccine candidates. There are a whole host of treatment options, and one of them is using what is called hyperimmune serum, taking people, many people who have gotten the disease and gotten over it, isolating just their immunoglobulins, pooling them together and using them, this highly concentrated anti-COVID-19 anti-serum as a therapeutic. So the steps there are first identifying and purifying it and concentrating it and then making it into a therapeutic. Those trials are underway. And I was on a call with the chief of staff of the biologics division of FDA, who announced to a group of us researchers that they had created a fast track process for authorizing the use of this what's called convalescent serum modality in individual patients, and they expected to have the hyperimmune serum, the second thing I mentioned, in clinical trials as soon as July, which is astonishingly fast.
All right. In terms of masks, I know that I heard that it's only important if you have it, so it doesn't go anywhere. And what kind of mask is the best? And can you get it by breathing it in, or just by touching surfaces and into your mouth? Can you just breathe it in directly? How does that all?
Ken, you want to take that?
Yeah, I can start with this. I guess I'd like to talk about 3 different kinds of masks that have been discussed in our community. There's the N95 mask, there's the surgical mask, which could be called the 3-ply as well. And then there's masks that we might make ourselves with, go online, find a YouTube video on how to make a mask and sew it using the materials you have at home. But far and away, the best mask to use if you were to be a medical practitioner and to try to treat people that are sick would be an N95 mask. That has the smallest amount of pores, so that the virus has a more difficult time getting in and being breathed in or consumed by the medical practitioner. But none of this is foolproof. If that mask doesn't fit correctly, if it's not used correctly, and there's all kinds of ways to use a mask incorrectly, then someone could still get sick. So they're never a guarantee, but they're certainly helpful. As far as the general population, if you're asking about, for example, if you're going to go to the grocery store, should you wear a mask? There are some advantages and there are some disadvantages. And again, there's a lot of very intelligent people that are giving different answers. And in fact, in China, there was in certain locations, there was a law that you must have a mask when you're out in public. And there's other locations where they've stated that you are not allowed to have a mask in public at all. And these are smart public health organizations in each of those countries that have given these varying discussions. Again, if you're part of the general population and you're wearing a mask, actually the most effective reason to wear that mask is to prevent you from giving it to yourself. So if you have a mask that's covering your face, then that stops you, it should stop you from taking your hands that could potentially have it. Even if you're wearing gloves, if you're wearing gloves in a grocery store and you pick up a can of tuna and you look at it and then you put it back and someone had just sneezed on it. And then later on you take your gloved hands that had just touched this can of tuna and you touch your face. Well, the gloves didn't do any job, didn't do a good job. So when I went grocery shopping this morning, I gave myself a little mantra before I went in there, and I practiced on my way on the drive that I will not touch my face. And if a little piece of my face itches or feels like it wants to be scratched, I will resist that and let it pass. So if I were to have had a mask on and I tried to scratch my face through the mask, I probably wouldn't do that. But that's one of the biggest things that a mask would actually end up doing for you if you have that. The surgical masks that you see in all the, if you're clinical or if when you've been to a clinical environment or you see on TV, those masks that don't fit as nice and neat as the N95s, some of which have these respirators on them and some of them don't. The main job of the surgical mask is to prevent what it's designed for is to prevent a clinician, let's just say a surgeon in this example, if you're doing a procedure, from giving anything that you might inadvertently have as a surgeon to your patient who, let's say, is opened up and is immunocompromised. So that's what that would be for. So what are you all going to do about your own masks? And if you're going to be, first of all, they're not widely available, but some of you may have them, and some of you may want to sew them and create them for yourselves. Or there's still a question about would it be a good charitable event? And I've been looking this up, and I don't have an answer for this yet. If we as a community started sewing our own masks and did it in bulk as TBA, and we produced all these cotton masks and gave them to our healthcare providers, on the CDC website, it addresses this question. And it basically says those are not effective and they should not be used unless there are no N95s or surgical masks that are available. And if that's the case, then in that very specific circumstance, it would be okay to be using these homemade masks. John, did you have any comment?
No, nothing to add. Just echoing everything you've said.
If extended families live in different homes, mm-hmm. and each part of the family in their own home has been social distancing and self-isolating and all those things, can they get together amongst themselves and come together?
I think at this point we're talking about probabilities here. So every time you introduce a new person to the mix, then that's another person that could have it somehow and spread it on. Right now we are trying to limit that, and I know how difficult that is. I know for myself, my parents so badly want to see the grandkids and on all of their grandkids. And at this time, the rule we have in our household is we're doing that by video conference. The last thing we want to do, and we know that the older population is more vulnerable. There's an interesting phenomenon that is occurring in Europe and the United States. It appears, unfortunately, that there was reports out of Asia that the younger population were far less vulnerable. But in fact, we are seeing that the younger population in Europe and in the United States are getting it at higher rates than they got it in Asia. So what we want to be quite careful about it in either situation is if you have a younger asymptomatic individual, a grandchild, for example, getting together with the grandparents and then intermittently passing that. So I, at this time, would recommend holding back on that no matter how hard it is and coming up with other creative ways to interact with your loved ones.
One of the questions that I think is on a lot of people's minds, I'll just address. It has to do with if you are sick or you've had this, how do you know when you're safe, right? When you are over it? And there is no good answer to that question yet. I can tell you the anecdotal experience that I've had in conversations with other physicians. And it follows general good practice about illnesses, about viral illnesses. The way your body clears a viral illness involves the use of your body developing immunity, antibodies, and other mechanisms to clear the virus from your system. And that, generally speaking, coincides with your wellness, with your physical recovery, so you feel better. So the rule of thumb is that you are likely to be over this and free of the ability to pass the virus along if you are 2 to 4 days without symptoms. So in other words, feeling completely back to normal for more than 24 hours, and ideally longer than that. The one thing that I'll say about the clinical course is that this virus appears to have a relatively insidious course, that the time from when the people who are most sick and wind up in the hospital and even in the ICU, from when they first get symptoms until they need hospitalization is more than a week. And their usual presentation is with some cough, some shortness of breath. One of the characteristic symptoms that people are reporting for this virus is the loss of the sense of smell. So, that's not a typical thing unless you have a completely stuffed nose to say, I just can't smell anything. But loss of appetite follows aches and pains, headache, GI distress. But all of that in the relatively mild and tolerable intensity over the course of a week before the virus begins to make you much sicker. If you're going to be in that 20% of people who are getting sick enough to require medical attention. And then those that wind up in the ICU do so another 7 days later on average. And then once you recover, there's another 7 to 10 days of recovery from that 20% who are feeling sick and needing hospitalization. So the overall course of this virus, from the moment you first feel sick until you're feeling back to normal, can be as long as 3 weeks. It really knocks you on your behind, I can say, from listening to people that have had it.
Mm-hmm.
So I think at this point we're going to call it a day. A couple of quick things before we finish those. A couple of closing thoughts. The prayer that I showed you is available at Ritual Well. If you sing the Shema, just the Shema part, Shema Yisrael Adonai Eloheinu, sing that through just the first part for the Shema. That takes about 23 seconds, so you get a little couple extra seconds in there. That works. Those words everybody knows. If you feel like you need to, obviously your own medical professional is the best person to check with personal things. Don't just show up at a testing site for all the reasons that you've heard. So that's important. And a Passover. I have 3 separate Zoom calls within the next 2 days with colleagues from different organizations about doing something online. So next, for the second night of Passover, we will do a TBA virtual Passover experience online. More information will go out about that. There is also a lot of resources available, not just about Passover, but in general. There are all sorts of things that people need and that people can do. So one thing is that we want to make sure, if you know of things that are, if you know of available resources, please share them in the chat if you're comfortable with doing that, or share it with me, because I'm going to take the screen back from you for a second, Danny, and I'm going to share this particular website, tbaonline.info. So basically this has, I can't see it. You can see it. I can't see it. Basically this, nope, hang on a second. There we go. This particular website has all sorts of information. It has ways to reach out to our caring community to offer and to get help. Ways that you can get available resources, ways that you can give things. There's stuff for bratty and for people of all ages in terms of opportunities to reach out. There are financial resources available. There are physical resources available. There are all sorts of things. And so we want to make sure that we're availing ourselves of those resources. The more you know about things that are available, like I said, put it in the chat if you want, send it to me directly if you want, and I'll make sure that this site continues to get updated. There's so much information to share, and there's so many things to share with all of you that it's hard to continually send you information. So just keep on checking tbaonline.info, and you'll see all sorts of information that's available locally in the city. Nationally, there are, like I said, financial resources, all sorts of things available for food and for and also ways to give to help as well. There are just myriad resources that people are talking about and sharing, and they're not limitless, that's for sure. But there are lots of opportunities for people to find assistance in different ways, and for people to offer assistance as well. So I think That is, yes, Passover I mentioned. Parents, please answer the poll question so we know what a good time would be to do this presentation for kids, an age-appropriate presentation. I want to thank all of you for being here. You're the most important part of this afternoon. And the second most important part of this afternoon would be Danny Slaim and John Edelman. Yeah, I see some of you who know the way you can applaud and give a thumbs up with the animations at the bottom of your screen on the right. People are doing that in all sorts of ways. So it's really just important that we continue to connect with each other and continue to reach out to each other. Again, technology. If you are technologically deficient in some way because you either don't have a computer at home, kids are going to be online for school, you have online stuff for work. If you need if you need a second computer or a third computer for whatever reason, because you have two people doing things we have hundreds of computers available, and they are gifts to you if you are in need. So please reach out to me directly, let me know. And I will make sure that you have, there are laptops and desktops and all sorts of things loaded with software available through this nonprofit organization. If you need help accessing technology, it's available. I have it, and so I will be happy to make sure you get it as well. And I think with that, I could go on and on, but I just want to say thank you to Danny and John. Any closing thoughts from either of you?
Well, for me, I just want to say I hope this was helpful. It's my belief that information is more beneficial than pretending like this is not serious, because it is serious. And, I wish everybody well. I know it's difficult, but I know we can get through it. And I am very, very confident that it will not be too long before there is a recognized treatment that works, that the most sick among us, the most severely affected, will be the first to get it, and that will really make a difference in how quickly this pandemic comes to an end.
And I'll say it's two things I'd say. One is that it has been a real pleasure preparing for this discussion with Rabbi Lazar and with Dr. Edelman. I think that preparation itself was one of the most gratifying things of doing this today. But I'll also say that at times where there is a crisis in our lives, if it's an important but much smaller crisis than this, or a global pandemic, it's a time where it could bring out the lowest qualities in ourselves: fear, uncertainty, and doubt. It could bring out panic and anxiety. But it's also an opportunity for the strongest qualities in ourselves to come out as well. The leaders in ourselves, the leadership, the sense of community, the confidence, the willingness to help somebody in all the different ways that we can help people now. And I would invite all of you to reach in deep and find that leader in yourself and have that side emerge rather than the other side. It's easy to get panicked, but there's no reason for it. And you can be a leader too. So thank you.
With that, I want to thank everyone, and we'll look forward to seeing you at other things during the course of the week. We have Torah study on Thursday at noon. We have Adult Ed Wednesday evening. We have Michael Zimmerman, who's going to be doing a lunch and learn on Wednesday, and all sorts of other things. We'll get together this weekend. We start live streaming our Shabbat services. That's a new thing, so that's pretty exciting. More information will be going out about that. And there you go. So thank you very much. And if you want, I'm going to leave the meeting on for a short while. Those of you who are still interested in chatting with each other or whatever, it won't be a group thing, but you're welcome to communicate with each other for another few minutes. All right. Take care, everybody. Thank you so much. Stay safe and don't be a spreader. Watch that video from Max and Mel Brooks.
Bye-bye, everybody.
All right, bye-bye. Thank you.